So today I thought I would share more of an overview of bimodal neuromodulation for tinnitus treatment. I know many of your audience here have heard about it. I rarely get to dive into some of the detailed science behind it. I'm going to try to keep it light, not to be too sciencey, but I thought this would be a good event to share that with your audience and also to share data, clinical data, not just what I've been involved with, but multiple groups, independent groups working on bimodal neuromodulation. I think it's always exciting and encouraging when you see positive and consistent results, different groups working on the same topic. Now, each group has, subtle variations in how they're implementing it and proposed mechanisms of action, but all in all, they're implemented in similar ways and showing encouraging results. So that's the goal for today. Now, before I begin, I am part of the University of Minnesota, and it's important that I, have my disclosures. As Dr. Thompson mentioned, I am part of Neuromod devices as a secondary role to my university role. I have financial interest, so that needs to be presented here, to your audience. I'm also part of another company, Second Wave Systems, that will not be relevant for today's talk. It's been fortunate that I was able to get data from multiple groups that they allowed me to share. From Neuromod devices, of course, but also from Hanover Medical School in Germany, that they were able to have real world data with bimodal neuromodulation. And most recently, Dr. Rich Tyler, which many of you know, presented on bimodal neuromodulation with a Bose Corporation device that he was able to share a few slides. I kept it short, though, that I will also present data from University of Iowa. So the real question for your audience is why bimodal neuromodulation? I just want to simplify it down in a sense that there's two modalities that I think of here that are quite encouraging. You have sound therapies or sound devices, and those can, as we know, can be effective for many individuals. They aren't in the clinical guidelines, what's recommended, not because they're not effective, but there's certain kind of clinical trials and data that has to be collected for it to be in guidelines. But it can be effective. It's convenient to use and can be taken home, and many people feel comfortable using them. However, they may not be effective or have a large enough therapeutic effect for many individuals, and the effects may be transient, right? On the other side, you have psychotherapy, cognitive, behavioral approaches. Those are in the clinical guidelines. They can be quite effective and long lasting, though there is some commitment and time period for those effects to, take effect. So what we're thinking here is there a way to merge, the best of both worlds? Can we create something that can drive stronger changes in the brain, but almost still represent itself as a convenient option like a sound device, right? And in order to approach this and try to figure out how to enable this to improve, the bothersome level or the tinnitus awareness, to reduce the tinnitus awareness to the tinnitus, the question is how do we approach that? And here, what I'm going to show you is just a very, very simplified schematic of how we think tinnitus could be coded in the brain. And then I wanted to go through a few slides to give you a sense of how bimodal neuromodulation may work to reduce the bothersome level or the awareness to tinnitus. So here you have your brain. Sound enters the ears and vibrates middle ear bone structures and the fluids in your cochlea, the snail-looking object here. And that causes activation along your auditory nerve that goes to your brainstem, up through your midbrain thalamus, up to your auditory cortex. So there's a pathway, auditory pathway, and it's going to allow you to perceive sounds. Now, many individuals, for me, I believe most individuals have some form of hearing loss that have tinnitus. Some of this is very mild or in very high frequency regions. But due to this reduced input into the brain, for a subpopulation of individuals, there is this gain. Now, what we define as gain, we're just using the word gain, but it's quite complicated in what the brain could do to increase that gain. But it can actually increase the loudness somehow of a sound that's created, or it can make you more aware of a sound that's being coded in your brain. But the idea is that there is this increased perception or awareness to what we call this tinnitus percept. Now, the question is, how do we shut that down? The loudness, but also the awareness, emotion related to it. Now, we know sound approaches can be effective in interacting with the tinnitus cells in your brain. We know that because if you play sounds, it can mask your tinnitus, it can interact and even cause some residual decrease or residual effects on your tinnitus over time. Now, the thing is how do we make that more strong, more potent, right? To make it a larger effect or a longer lasting effect. And this is where the concept of paired stimulation comes in, where you would take your sound, present it to interact, but then reinforce it with another non-sound input. And that could be, for example, electrical stimulation of the body. And in a very simplified way, we would view this as, reducing awareness as some kind of super sound therapy. And that's kind of a simplified way that I could present it, is that think of it, you have sound therapy, but now we're just creating an enhanced sound therapy approach. So the next question then becomes, would this even work? What data or what evidence do we have over time, over the past research that bimodal neuromodulation can work for tinnitus treatment? Now, there's already been over 100 years of research doing paired stimulation to alter things in the brain and your awareness to different things, from behavioral effects, which I'll get into with the Babylonian dog. Many of you are familiar with the dog that becomes sensitive to a bell that's paired with food. But there's also, in the last 30 to 40 years, evidence in the auditory brain that you can change coding of cells in your auditory brain directly by doing paired stimulation and in systematic ways. So I'll present some of that as well. And then the last bit here is more in the last decade, a few groups, including my group, have been trying to figure out connections that you can actually access, not only sound, but for example, body stimulation that could tap into these pathways that could interact with regions relevant for tinnitus. And that has been work that I'll present that I've been involved with. So let's jump to the Babylonian dog here. Everyone's familiar, hopefully, with the Babylonian dog. You have this dog here that if you present food, it'll salivate. If you present this bell, it will not care about this meaningless bell. Now, if you combine both of them together, you present the food, you present the bell at the same time, then the dog's brain creates this association with the food and the bell. So next time when the dog hears the bell, the dog will salivate, even though the food's not there. Now, interestingly, it can work with lots of different stimuli. And in these studies, over 100 years ago by Dr. Pavlov, even the staircase, walking up the staircase, the sound of that made the dog salivate because a dog associated that food, that strong reinforcer, right, with that bell. So you can make your brain more sensitive to something that it was not too, sensitive before. Now, you may wonder, what does that have to do with tinnitus? I kind of like what Glenn was talking about earlier in his talk was, get out there and try to allow your brain to focus on different things. Now, imagine if you can make your brain focus on different things and become more sensitive, and then you train your brain automatically so that it keeps focusing on different things and less so of the tinnitus. So you can imagine here, if you make your brain sensitive or more attending to all these different stimuli that you present to it in a reinforced way, then indirectly or inherently, it has to decrease its attention to the tinnitus. So that's the premise of where we're going to move towards. Now, I like this plot. I know it's dense, but it's one of my most favorite and exciting plots that I came across as a scientist during my PhD days at University of Michigan. This was results by the late Dr. Weinberger. There's multiple groups that do this kind of research. But what they did is they took animals, guinea pigs, and they recorded from cells in the auditory cortex. And this is where we believe at least some forms of the tinnitus are being coded. And what they did is they recorded from this cell in the auditory cortex. And these cells in your auditory system like different frequencies. We say in your brain that the cells are ordered based on what frequency sounds they like. And this is not only for the auditory system. If you think about your visual system, you have cells that like certain locations of your visual scene. Your body, you have cells that code for your finger, that code for your leg. So there's this topographic map of cells. So if you look at a cell in the auditory cortex, this one cell might like 1 kilohertz sounds. And so let me guide you through this plot here. If you look at the x-axis, this is different frequencies that we're presenting. So you could present a 100 hertz sound or 0.1 kilohertz, a 200 hertz sound, a 1 kilohertz sound, a 10 kilohertz sound, 20 kilohertz. And on the y-axis, you don't have to worry about, the complexity there is, except that up means that the cell likes it better, okay? So then you have this green curve and you play 200 hertz, you play 400 hertz, you play 1 kilohertz sound, like a piano, you're kind of going up the piano here. You play 1 kilohertz and this neuron loves that sound. you could see it's very high. The green curve is very high number. And then as you go to higher frequencies, it doesn't care so much. When you play 10 kilohertz, the neuron doesn't fire much. It doesn't have much activity. So we say this cell is tuned or sensitive to 1 kilohertz. Now, this is what was very exciting and impressive, is that then what they did was they played 2.5 kilohertz sound to the guinea pig's ears while they're recording from this cell. And they electrically stimulated the body. You could do this in different body locations. At the same time, they played the 2.5 kilohertz. So they're playing the tone, but they're giving a reinforcement signal to the body. And they only did this 30 times. And what happened then is something that we thought was so fundamental to cells in your brain, you could shift it. You can move these cells to code in different ways. And so what you see is the orange curve. The orange curve, still not that sensitive to 100 hertz, 200 hertz, 400 hertz. Look at this though. It doesn't care as much about the 1 kilohertz. Interestingly, it cares about the 2.5 kilohertz, the one that you presented and paired the body stimulation to. And then as you go to higher frequencies, it doesn't care so much. So what you notice here are 3 things that I want you to pick up on. One is you made the cell, its identity change. Before it loved 1 kilohertz, now you made it more sensitive to a different frequency, in this case, 2.5 kilohertz. The other piece here is that you made it less sensitive to the original sound. That's exciting because it tells you you can start shifting these cells in systematic ways by pairing the inputs. We call this homeostasis. Your brain can't be sensitive to everything. And why I would also argue Glenn's comment about distracting yourself, your brain can only be sensitive or focus to a few things at a time. And then the other thing is you do get a little bit of excitability overall. As you can see, the orange curve is a little bit higher than the green curve. So that's exciting. Behaviorally, we know this can work. Physiologically in the brain, we know things are changing and it's possible. The big question now is which body regions do we stimulate and how do we implement this in a practical way? And so what we were able to do, because we know that lots of body regions project to the brain, we were able to stimulate lots of different locations in the guinea pig, play sounds, and long story short, we found 2 regions to be quite effective. The ear region, when you electrically stimulate it with sound, and the tongue, if you electrically stimulate the tongue. So these are the 2 regions I got very excited about and started to pursue in my lab and in partnerships with other labs. So I'm gonna go through this here. I realize time went by quicker, but here's your brain, very abstract view. You have your cells here that are representing the tinnitus in your brain, the triangles. Now, if you play sounds, pure tones, you're gonna cause these circle cells to light up. And it's gonna somewhat hide or mask your tinnitus cells because your brain is kind of being distracted and can't focus on the tinnitus cells and the sound-induced cells that are being activated. And it happens with different sounds. And then if you turn off the sound, then what you're going to get is the tinnitus that's going to remain there afterwards, right? And sometimes you'll get residual effects. Sometimes you'll get things that are altering, but typically they're transient. Now what we're going to do is use bimodal neuromodulation. We're going to play the sound and we're going to pair it with, in this case, tongue stimulation or another body region. And when you do that over and over again, you see the circles, but they're enhanced circles now. They got this, this electrical stimulation symbol. And what you see is that things stick around, things shift. As I showed you before, you're shifting the coding of cells, right? And as you make other cells more sensitive or active, you're going to cause the tinnitus cells to calm down a little bit. And that's because of this comment I made before about homeostasis. Well, you do this again with another tone, another tongue stimulation, and you'll cause this to happen even more. The tinnitus will become even less noticeable, or you'll be less aware to it. And if you do this over and over again, many, many times, the idea is that eventually you normalize the tinnitus into a softer, less aware state. So question is, all this science work, all this research, but clinically, does this work? And multiple groups are fortunately pursuing bimodal neuromodulation in various small and large scale studies. One group of studies, which I'm involved with, is with Neuromod devices. They've been able to pursue so far and publish on 2 large-scale clinical trials in 326 tinnitus participants for 10A1 and 191 tinnitus participants for 10A2. The first one, they demonstrated and supported the safety and efficacy of using 12 weeks of sound stimulation with tongue stimulation to reduce the symptoms of tinnitus. And from that, we then built upon that knowledge to look at different stimulation settings to show that other types of patterns could be effective. But what I think was, for me, the most exciting was that in 10A2, we were able to adjust the stimulation parameters midway and drive further improvements in tinnitus. And this is shown in this data here. I promise not too much complicated data plots, but this one captures the summary of these two studies. I want to make a caution that we are pooling data from different studies, so you have to be a bit cautious in direct comparing, but I wanted to provide this data in this format so you could get a sense of the kinds of effects you're getting across studies. So if you look at CBT and usual care, this was from a seminal publication or study done by Sima et al. A few years back, 2012. And you see on the y-axis, it's a tinnitus score, tinnitus handicap inventory. And what you need to know from there is negative means improvements in tinnitus symptoms. You see that for usual care, especially for cognitive behavioral therapy, you are getting an improvement over time. And 7 points is what's defined as clinically meaningful. So this is very encouraging. You get this improvement with cognitive behavioral therapy. Now, if you look at 10A1 study with bimodal stimulation, the gray curve is when we gave the same stimulation strategy for 12 weeks. 6 weeks was synchronous, but it continued on for second 6 weeks, and we evaluated at 6 weeks and 12 weeks. Then we took the device back and tracked it for a year after the treatment had stopped. And what you notice here is you get this rapid improvement during the first 6 weeks that then plateaus off. Even during treatment, you don't get any much additional improvement during the second 6 weeks, and you get the sustained effect. What was interesting though, and encouraging, is in 10A2, because of this plateau effect, we actually swapped the stimulation strategy midway. So for the second 6 weeks of stimulation, and we did in a way that the individuals could not perceive that change. It was done with delays that are imperceptible. And what was exciting, you see, for the green curve is we're able to drive further improvements in the tinnitus symptoms down to about what you see here, 21 points, about 3 times the clinically meaningful improvement. And as you can see, after the treatment stop, it could be sustained. So this gives us a sense that different stimulation settings can be effective, but you got to keep the brain active. You got to, and again, to what Glenn was saying, try to, imagine keeping your brain on its toes and having it focus on multiple things to be able to keep driving distraction or these improvements. And that's what we're doing here by providing different stimulation settings. And just sometimes when you present tinnitus results with these questionnaires like THI, it's hard to grasp what it means from a qualitative, right, an experience perspective. And so we simply just asked in this most recent study, 10A2, did you benefit from the bimodal treatment? And we had 70% say yes, they did. And we asked, would you recommend that they try this treatment to someone who has tinnitus? And we had about 88% for this most recent study. Now, when you're in a clinical trial, the question is, does it translate to the real world in the commercial or clinical setting? And so this was one of the first sites in Europe. It's available in Europe, not yet in the US, but in one of the first sites in Europe, they had patients come through. So this is 20 of their first patients that came through their clinic. They received bimodal stimulation, initially the first 6 to 12 weeks follow-up that they had data for. And what's encouraging is you see the green plot, they had an improvement of about 10.4 points. Now, it wasn't as high or as much as we saw in our clinical trial, still pretty close. In our clinical trial, the first 6 weeks was about 12.9 points improvement, but it's expected because there's greater heterogeneity and complexity in the real world. But this is showing that real world data can track clinical trial data. And on the bottom there, you just see that individual patient data, you see on the left side, the green, negative meaning that there was an improvement. You see, different amounts of improvement for each of these bars. Each of these bars is a different patient. And what we found encouraging was that you could see for 10A2, the distribution, the shape of this distribution is not too different from the real world data. So all of this points in the right direction. You've got clinical data supporting this. You've got real world data supporting this. Now, the question is, can it be repeated by other groups and other methods, modalities? And the question is, so far it appears so, yes. Now, this is a different approach. I was excited to see this when Dr. Rich Tyler presented it last summer. Some of you may have been at that Tinnitus and Hyperacusis conference. Their approach was working with Bose Corporation. Some of you know this Bose headphone, noise canceling headphone. They paired this with a device you see on the bottom left here with electrical stimulation. There's they're ear inserts, but they have electrodes that stimulate the ear, your ear region. And they provided this for 6 weeks of stimulation. What's interesting is this is how I would have done it. They took a notch at the tinnitus frequency. So these are the individuals who had tonal tinnitus, and they basically presented the electrical stimulation with broadband noise with a notch where the tinnitus frequency is. And they repeated this 30 minutes per day for 6 weeks. And encouragingly, they showed that a majority of the tinnitus participants improved in their tinnitus symptom scores. Now, they're using a different questionnaire, but they basically showed in that questionnaire that 10 out of 11 had some improvement. 5 of the 11, so about 50%, had a significant clinically related improvement. So that all, again, is pointing in the right direction. I know he has this data in publication or in review, so hopefully you'll all have access to this not too far in the future. And finally, the last data I just want to share is this was a seminal paper that was published in 2019 by Dr. Susan Shore's group, or it might have been 2018, sorry, in Dr. Susan Shore's group at University of Michigan. They are doing electrical stimulation of the face or the neck region, trying to tap into some of the earlier research showing trigeminal stimulation. And they are pairing it in the guinea pigs with pure tones, but they've done more complex sound aligned with the tinnitus and adjusting some delays to try to suppress the tinnitus loudness. But regardless of the subtle differences in the approaches, they are using bimodal stimulation. And again, here, they provided 4 weeks of treatment in humans, and they're able to show significant improvements in tinnitus symptoms that could last for at least 3 weeks post-treatment. So I think when you take it all in totality, it's quite encouraging for the field. You have multiple groups working on bimodal neuromodulation. There's subtle differences in how they're being implemented, but it's showing that bimodal stimulation is causing some changes in the brain, is affecting tinnitus cells, right? Or cells interacting with the tinnitus percept. And it has been relatively easy to use or well, tolerated to use. So that's exciting. Now there's a lot to be investigated still in terms of optimal stimulation strategies and who best benefits from each of these different stim patterns. But I think through this presentation, you'll see that there's a lot of potential for bimodal neuromodulation. So all of us are quite excited for where this can be in upcoming years. And hopefully that gives you a good snapshot of the bimodal neuromodulation field.